Um, Thank you for joining us today, and we are going to have a great presentation today and appreciate your time. My name is Becky Sanders. I am the Program Director for the Upper Midwest Telehealth Resource Center. Everyone has been added to this webinar in listen-only mode. You have the option of using the Q&A function at the bottom of your screen to ask questions. And we encourage you to put those questions there so that we can track them. If there's questions we don't get to today, we will create a frequently asked questions document and send those out to all attendees after the webinar. We are going to be recording today's webinar. It will be posted on the UMTRC YouTube page as well as the UMTRC website under archived webinars. We'll also post the slides from today's event. Just a couple of things before we get started. I do want to thank you for joining us today for the UMTRC webinar series. Next slide, please. The UMTRC is one of 12 regional telehealth resource centers around the state. We cover the states of Illinois, Indiana, Michigan, and Ohio. There are also 2 national telehealth resource centers, TTAC, which is our National Technology Center, and CCHP, which is our National Policy Center. Next slide. The National Consortium of Telehealth Resource Centers, all 14 of us together, do have a common website that you can see here and also offers a monthly webinar as well as resources on their website. Next slide, please. This is the link for the Center for Connected Health Policy, and they just recently released their, go ahead, next slide, their spring 2020 snapshot of all 50 state Medicaid programs. You can see some information there. All 50 states and the District of Columbia do now have a definition for either telehealth, telemedicine, or both, and all 50 states do reimburse for live interactive video telemedicine. Next slide. There's some other interesting facts about the different states across the United States. 42 states and the District of Columbia do have some type of a private payer reimbursement. So that's commercial insurance, Anthem, United, Blue Cross, Aetna. And then there's common restrictions about services and how they can be provided. And many states do also have laws on the books about online prescribing and licensure. Next slide. This is the link to the TTAC website, the technology website. As a federally funded organization, we have to stay vendor agnostic, but they do a lot of toolkits and to help people pick different platforms for their telemedicine programs. Next slide. This is the link to all of the different toolkits on the TTAC website. And here at the UMTRC, we are kind of like virtual librarians. We do a lot of consultation with folks, programs like what we're going to see today, trainings, and just answer a lot of emails and questions. Next slide. So at this point, I'm going to go ahead and introduce Brenda Jagatic, who will answer or will introduce Tony Song. And just as a reminder, please use the chat function only if you have technical issues, and the Q&A function if you want to ask a question of Tony or Brenda or myself. And we were talking before we got started today, and I'll put this link into the chat. There's a study and a website out there where you can track telemedicine events or different sessions, and there's been almost a 4,000% increase this year for telemedicine sessions with COVID-19. So Brenda, without further ado, I'm going to hand things over to you.
Okay, thank you. Thank you. It's my pleasure today to welcome everyone to today's webinar, and that is Learn How a DSME Program Went from 12 Programs a Year to over 500 Using Telehealth. My name is Brenda Jagatic, and as you can see, I am the Diabetes Education Coordinator at the Indiana State Department of Health. And my role has been primarily is to increase diabetes education in the state of Indiana. And this has included collaborating with Becky at the Upper Midwest Telehealth Resource Center in providing technical assistance to diabetes programs that are interested in delivering services via telehealth. And what I can say in my telehealth journey of 5 years, where I slowly have been increasing my knowledge and skill around this, I had the opportunity to collaborate with Tony Song and tap into his vast knowledge and experience. And today it is my pleasure to introduce to you Tony, who is the passionate CEO of Diabetes Care Partners. And they have been delivering telehealth for 8 years, and with the onset of the COVID-19 pandemic, they have stepped up delivery of diabetes self-management education services into the homes of people with diabetes. And although Tony's company is in California, and it's a business entity versus an outpatient diabetes program, which most of the diabetes programs are, I still believe that health organizations across Indiana and across the US can learn from his experience and his perspective. And it's my pleasure to welcome Tony.
All right. Let's see here. Thanks. Appreciate that, and thank you all for joining us today. First of all, I wanted to thank Becky Sanders and Autumn Daniels from the Upper Midwest Telehealth Resource Center for setting this up. I also want to thank my friend Brenda from the Indiana State Department for really starting this journey and this process of getting this this webinar going. Without her, this would have definitely never happened. So thank you, Brenda. So today, I'm going to show you how we grew our DSMES from 12 to 500 programs a year. I'm going to show you the steps we took to get to where we are today. I'm also going to reveal 3 secrets to our success that helped us along the way. And if that wasn't enough, I'm going to give you a little gift at the end of this presentation. So please stick with us till the end. Okay, so as Becky, as mentioned, my name is Tony Song. I'm the CEO of Diabetes Care Partners. I call myself the Diabetes CEO because number one, I am the CEO of the Diabetes Care Partners, and I live with diabetes myself, giving me, I believe, a special and intimate perspective to lead my organization through the eyes of the people that we serve. We, as an organization, help health systems and organizations get better diabetes outcomes with their members. We call all our patients members, by the way, so you can kind of interchange the two. And we improve HEDIS measures, increase access, and ultimately provide more value. That is our goal for all our stakeholders. We provide more value. That's really important for us. So, you know, I believe that you all are here because you have a passion for making a difference in others through your work. You know, that's why I'm here. So today, I hope through this webinar that you can scale your efforts to make a bigger difference and impact for those who live with diabetes and needs you. So if you're with me, please comment in the chat box. I'd love to see if we can get some interaction going through this webinar, because I think that's how we learn the best. All right, cool. So I always like to start off our presentations or any type of presentation with a mission. Now, this is our mission for our company. We truly eat, drink, breathe this mission. And it's to increase access to outcomes-driven, meaningful, innovative solutions and support for all people living with diabetes. All people, that's our goal. If we could reach every person on this planet that has diabetes, that would be our ultimate goal, right? And it's really important that I show you this because what we've done over the last almost 20 years is we've looked at every small but definitely big decisions that we've ever made and put it up against this mission. And if it made sense with our mission, we went with it. We took the risk, and you'll see what we actually did to get to where we are today. And you know, the risk for better or for worse, to be honest, there's a lot of mistakes that we've made over the years. And I'll talk about some of those too. So, you know, I couldn't really start our journey, telling you about our journey without giving the credit to my wife, Kelly. That's Kelly. You know, she's really been the foundation of support that has driven the success and really comforted the disappointments and pain to get to where we are today. So I have to give her credit. This is a picture of us when we first opened our office in West Covina. I definitely was a lot younger, more hair, and definitely a few pounds heavier. But I definitely have the same passion as I did back then to make a difference. And that's the reason why we started this company. I also want to make sure that it's clear that I'm not a special individual. I'm no smarter than any of you out there. But what I feel is that I have used 3 secrets that I told you I'd tell you about during this presentation that I'll share with you that has really helped us to get to where we are today. Not only to expand our program into telehealth, but really to become a better program in general. And I definitely want to share that with you. So let me take you on our journey. So we were founded in 2002 with a mission to increase access in West Covina, California. Eventually, we actually opened up another office in Pasadena, California. And most people know that's the home of the Rose Parade. By doing that, we were providing 12 to 24 programs a year, and we were covering a 25-mile radius. One of the things that we realized is when we opened up another office, it wasn't really the best business decision to make. Although the volume was there, the overhead was definitely high, and eventually we had to close the Pasadena office, but we replaced it with telehealth. Okay, so in 2008, you know, we're talking access. So how do we create access? So we decided to build a mobile education unit, and you can see it right there. It was a very nice unit, and we took it all over the place. Helped a lot of people that didn't have access to our West Covina and Pasadena office. So we went from 25-mile radius and 12 to 24 programs to 48 programs per year, and covered a 100-mile radius for our members to take our program. Now, the reason why we did that was because we knew that we needed to increase access. So how do we do that without actually opening up another office? Well, this was our solution at the time. And so we did this actually for 3 years. Like I said, we affected a lot of people, but operating a mobile education unit requires a lot of logistics that have to happen. So eventually, after 3 years, we sunset the program because, again, you know, we started to look at telehealth. We definitely learned a lot from this project, and I, you know, to be honest, I still believe that a mobile unit may be the future that's coupled with telehealth services. That could be something that we look into the future to do. But you can see that we increased our program numbers and our access quite a bit just by having this mobile unit. So then, in about 2011, we were introduced to somebody that changed everything. We were introduced to an individual by the name of Quan Louie. He's a telehealth pioneer and an expert in the field of telemedicine. He runs Telehealth Docs, which is a specialty telehealth company. They have all sorts of different specialties, cardiologists, psychologists, everybody. But I spoke with him and he told me about this new way to increase access that he's been using for a specialist. So that's when I said, wow, well, you know what? Maybe this could work for diabetes education. And I started to learn everything about telehealth at that point. Well, with his help, we started in 2012 a telehealth pilot serving a rural health center in California border of Nevada. Then in 2014, we partnered with a Native American Resource Center to provide telehealth diabetes support near the Oregon-California border. These were our first entries into telehealth. And you can see by the picture, and that picture was actually taken and put into the local newspaper up in well, they're in Portola. And that picture on the screen, that's one of our educators. Her name is Ginger. But this is how we learned, right? And really from this, we increased our program numbers to 72 programs per year. And now overnight, we were able to take care of an area of 600-mile radius. Unbelievable. There's no way we could have done that by opening up another office. No way we could have done that by having a mobile unit. No way. So in 2015, we partnered with our first Medicare Advantage insurer here in the California area. And we've started to provide telehealth services for 16 counties in California that reach from the Bay Area all the way down to the border of Mexico. Now that gave us 360 programs per year, and it covered 800 miles, all through this technology. You can see how powerful it is. And then just last year, in 2019, we partnered with the nation's largest publicly operated Medicaid health plan. They manage almost 2.2 million members, and we're helping them develop and facilitate telehealth diabetes self-management. This is going to be a game changer for us. We're definitely going to be able to take care of more than 500 plus programs a year. And again, we are still in California, so it's 800-mile access that we provide. And really, due to the COVID emergency and through the 1135 waiver, we are now in the process to provide home telehealth services that wasn't even on their radar before. So what I mean by opportunity, we have it right now. People are actually asking for it, right? So we need to take advantage of that. We need to seize this opportunity now. And everybody that's on this call, I'm gonna make a case to you that if you're not starting something today, shame on you, right? And then this is kind of an off thing I really want to share with you. In 2019, we were honored to be selected by the CDC for a detailed on-site multi-day evaluation of our telehealth program to assist other diabetes self-management trainings and DPP programs across the country. So what did this give us? Really, I think it's priceless, because we realized although we're growing our program organically and reaching more and more people every day, we are still limited to our own growth. Yeah, we felt through this partnership with the CDC, we are now able to empower other programs to grow. And that is why we're here today, trying to fulfill our mission with all of you on the call, because we can't do it alone, right? Just a real funny, quick story. So, this was a big deal. It was a multi-day, and you can see that they sent multiple people. They had 5 people come to our site, and they wanted to know exactly how we work and what we do and how we're getting the results that we're getting. So one day they all took a field trip to one of our remote sites. And the saying, well, Murphy's Law, anything that can go wrong will go wrong at the wrong time. Well, exactly, that's what happened. We were at the site and we couldn't get connection. for some reason, we weren't exactly sure. But of course, you know, we had a plan B and we actually had a plan C too. So we implemented plan B and we got everything working again. But this is a story about technology that you're gonna run into things that are gonna be problems. And, you know, have a plan B and a plan C, because these things will happen at the worst time. And you can imagine the CDC flies from Atlanta. They all stay in a hotel for 3 days and they you know, evaluate our whole program. And the time they're at a remote site, everything fails. I was shocked, right? But we knew exactly what to do, right? And that is what you're going to experience as well. Don't give up if you have any failures. Continue going forward.
Tony?
Yeah.
We had a few questions in the question box, and I know you and I had discussed earlier that you wanted to make this as interactive as possible.
Sure, absolutely.
And so Nicole had a question. She wanted to know, with your telehealth visits, are you doing insulin adjustments and pump adjustments with the telehealth?
Right. We have pump trained CDEs on staff, and they do that. But I'd say it's very a small amount. I think the majority of our members that we take care of, Medicare and Medicaid, are not on pumps. And we do limited amount of type 1s because, I don't know, for some reason we don't get those referrals. So the majority, 97% of our referrals are usually multi-daily injections with an insulin syringe, or on oral medications.
Okay. And do you have some kind of like a arrangement with some of your providers who are refer to telehealth that have insulin to make adjustments or discuss things and get back to the patient, or?
Yeah. So with especially endocrinologists, we have a protocol set with them, with our CDEs, to adjust insulins depending on that protocol. And so long as we stay within that protocol, and usually after the adjustments, we will go ahead and send the progress note right away to the referring physician, usually the endocrinologist.
Yes.
That is our agreement with them. So you have to take a case-by-case basis. We realize that takes time, though, because you really, I mean, the physician really has to trust your ability to do the work that they want you to do. So those agreements came over time.
Yes. And so I have another question from Jack. Do you collaborate with primary care for member total well-being?
Yes. So, you know, our goal is not to be in a silo. And any program that's out there that is in a silo is doing injustice to everyone involved, especially the member or the patient, right? Because we have to work together. Every time a member comes to see us, a progress note goes out the exact same day. It has to, right? The physicians have to know, and especially if there's something that we need to do for the member right away, that phone has to be picked up and called. You got to make sure that the referring physician, because that is the communication that really binds the relationship between you and the referrer as well, right? Because they're referring members to you. You got to make sure that that line of communication is always clear and big. And so every time a member comes to us, gets services, we send progress notes to the referring physician, and if they have two specialists, they'll go there as well. And we even go a third step. We have really good relationships with our payers. And we want them to know that, number one, we're doing our job, but number two, to keep an idea of what's happening with their members as well. So in a lot of cases, if it's a high risk situation, we'll go ahead and even send progress notes to the payer. And we have a contact person within the payer, maybe a case manager, a clinical coordinator, somebody. In some cases, we actually have these health coaches. We'll go ahead and get that information to them as well, because sometimes you just don't know if the physician is doing anything. So you have to create that circle of care around around the member, because if you don't have that, then you're going to get a lot of fall through to follow up, right?
Yes.
So you got to create that network.
Okay, and Susie wanted to know if you're in an accredited diabetes program.
We are ADA recognized since 2006.
Okay, so I just have a side question for you since we're going down this path. Is that has your relationship or communication with the primary care referrals, have they changed with doing more in-home visits?
No, I think the refers that were referring before are still referring.
Okay.
That hasn't changed. I think it's a little bit tougher to get somebody started, a physician to get them started, because we're not in their office anymore.
Okay.
Right? We're doing it directly to home. So they're, the way you got to think about physicians is that, number one, they are busy. They are taking care of a lot of people, and diabetes education may not be a top of mind. And so it's really critical that you're always engaging with them in any way that you can. And so what we were doing, we're visiting them. And when we were doing programs in their offices, they saw us every week, right? And so they saw the impact that we were making, and that we were part of their team, and we're trying to make sure that their practice is working better because of our involvement. And if they start seeing that, and they usually do, then that referral count starts to go up and up and up and up, right? Again, we can't live in a silo. If we do that, our program is going to die.
Yeah. So I have two more questions for you, and then we'll let you continue with your PowerPoint. So Priscilla asks, how do you provide progress notes?
Yeah, we fax them.
Okay.
Yeah, so, unless you're lucky to be within a system, a network where you can electronically send those securely, the only way that we know how to do that is by secure fax at this point.
Okay. And then Priscilla had one other question. She said, what are your outcomes?
Oh, I love to talk about my outcomes. There's really, so outcomes, it depends on who's asking, right? So if for insurers and for physicians refers, they're really interested in A1C. They want to know what the A1C results are of people that have come through our program. And the way we communicate that is, number one, through progress notes. Number two, they get to see their own A1C numbers from the payers anyway, so they could see an improvement or not. Three, we aggregate the A1Cs every year for each individual physician, and we send that to them so that they know, okay, so these are the 10 members that they sent us, and these are the A1Cs that were affected. Now, I'm not saying that it's that 10 out of 10 people are going to decrease their A1C, but I can guarantee you that on the average, we decrease that A1C quite a bit. And so our average across the board for all members that take our program are between 1.2 and 1.4 decrease in A1C. That's a total, right? If you're talking about insurers or payers, they are really interested in the high risk members, right? So above 9, in some case above 8. And so we show them A1C outcomes for those members. And usually for those members, we're at about a 2.4 decrease in A1C on average. There's been years that we've had an average of almost 3% decrease or 3-point A1C decreases for certain medical groups, right? So, so it really depends on that. Internally, what's really most important for us, outcomes-wise, is how the patient felt after taking the program. Did they feel less confused? Did they feel less frustrated? Did they feel less scared, alone? The feelings that we have with diabetes is really important to us, because we know that if we did our job, it would go from fear, anxiety, confusion, all these other things, to I'm challenged, but I understand it and I'm going to go forward, or I'm okay, right? And so we do this analysis. If you're an ADA recognized program, I forget what the term is, but there is a QI behavioral outcomes that you can pick. And that has been our outcomes one of the reported outcomes since the very beginning, because we realize that that is really the most important part of our program. Because if we can get that right, then we're going to get A1Cs down.
Okay. I'm going to take one more question and then I'm going to let you continue, but you're still getting, so the last question we'll take for this moment is, beyond the diabetic educator, who are the unsung heroes that we must collaborate with?
The unsung heroes. For us, and again, everybody's going to be different. For us, the unsung hero is the payer. Because, before, I would say, prior to 2010, 11, around there, the payers really didn't look at diabetes education as a really important part of the medical care, to be honest. And then when Medicare changed their rules and said, we're going to pay for performance, that's when they started picking things up and said, hey, you know what, this is really important to us, so we're going to do something about it. And they, the medical groups and payers that we work with are ones that are exactly aligned to our mission too. It is so easy to work with them if they align with us, because we have met and discussed diabetes education with organizations that don't believe that, have the same mission, always about cost cutting, and that's the bottom line when it comes to the discussion. We're trying to create value. They're trying to cost cut. And so I'd say for us, the unsung hero is the medical groups and the payers that we're working with, because nobody sees that they're doing this in the background, but they're really putting a lot of effort. They want to make sure that, that their members are staying safe and healthy. I mean, there's obviously a financial aspect to it that they're after as well. But I'm saying payers are not all alike.
So it almost sounds like you have an insight that perhaps most diabetes educators don't have, in terms of you have a very positive feeling. Is that because you connect with them? I mean, are you doing, becoming an in-network provider? I mean, are you having conversations with them?
Oh yeah. For payers, I would recommend, and I would recommend that every program pushes the payers to have meetings quarterly to show your results, because they're not going to ask for that meeting, probably because they're busy. But at the same time, you've got to always, just like with your physician refers, you've got to be there all the time. You've got to show them the value. And if you don't show them the value, then really you have no value. And so what we do is we make it an effort when we sign a contract, and it's not anywhere in the contract that they're sending us, we say, we want to meet with you every quarter. Is that possible? Is there somebody that we can meet with every quarter to show you what we've done and how we did it, right? That is the type of relationship that we want. Even if they don't ask for it, we want to give it to them. We want to continue to provide that value for them. I would recommend that every program do that. And again, physicians, the same thing. At least once a year, aggregate your data, send it to them. Say, hey, you know what? Thank you so much for sending these members to us. We really appreciate it. And look what we did for them. And look what we're doing for you. Because more than likely, they're probably making they're getting a benefit from that as well, right? Whether it's less headaches for them when they've been trying to take care of these members and nothing has changed. And then all of a sudden they go to your program and they come back, they've lost, 20 pounds and their A1C drops, 1.22 points. They're like, what happened? And then they're going to say, well, I went to this program and they did all these things. They talked to me as a person, and they figured out, and worked with me. And this is how I got it. Wow. What a great advertisement for your program. You've got to create that.
So I think, Tony, what you're really demonstrating is that to make this work, it's about relationships, making, good relationships, not just with your patient and your providers, but also with the insurance. because I know with my experience in helping a diabetes program deliver telehealth to a clinic, it was really bringing both sets of people, both groups together and getting to know each other. And one particular story I had was of a dietitian that was delivering the telehealth, met with the clinic telehealth, we call her a champion. She was a nurse practitioner, but they sat down and talked about, she heard what is most important to this nurse practitioner, what are the challenges she has with her patients, what is she hoping to get, what are her goals, and then in turn the educator explained, you know, what her services are, and she said it was just like magic how they clicked. Yeah. So I think a lot of this goes back to just building relationships.
Oh yeah, you know, that's what, you know, if you think about it, if anybody is actually running a business, I mean, that's what it's all about. You know, it's not transactional. If you think your business or your entity is all about transactions, you're going to fail. You know, it's got to be about relationships. Mm-hmm. How deep of a relationship can you create? The deeper, the better for you, for your survival, number one, and for more opportunities. And you know, that's the reason why I think that we've had so many opportunities over the years. You know, it's because of those relationships. It is relationship with your payer, relationship with your provider, referrers, and definitely the number one thing, and this is one of my slides, the relationship with your member. You've got to get that right.
Yeah. Wow. Well, thank you, Tony. We'll let you continue now with your PowerPoint.
Okay. Let's see, where were we here? Okay. So, you know, I would say that the technology, you know, this is a telehealth webinar. So we got to talk a little bit about technology, but I will say that technology is the easiest and maybe the least important component to a successful diabetes program. And I'll kind of tell you why a little bit later. But when it comes to technology, the most important thing is, does the technology work for your organization? Right? Meaning, what's the cost? How much space does it take? What's the ease of use? How well does it integrate into your process? These are all fundamental questions that you have to ask yourself before you choose equipment or technology. Because ultimately, almost all technology does work, but it may not work for your organization, right? So what I want to show you is what we've utilized for our different sites. So since we currently manage roughly about 40 remote sites, we need equipment that was, number one, off the shelf, right? It had to be simple, right? And it had to be affordable, right? So I'm going to show you three setup configurations that we use. The first one uses an iPad or a tablet. And you can see that it's just an iPad. It's got an adapter if you want to do a group session because it can hook up to a TV. But really, the iPad is the key. We use this for both group and individual sessions. This is the most versatile setup, in my opinion. Currently, we're lending this iPad to a limited amount of members to connect with our programs in their home, right? And these are connected iPads, meaning that they have a cellular connection. So they don't have to have a Wi-Fi in their homes. Although if they have Wi-Fi in their homes, obviously any tablet will probably do. And what's really important is that the cost is $300. $300, you know, that's not a big investment compared to you know, a Polycom, which can run thousands of dollars. So you know, if you get money from a grant for equipment and you want to scale fast, you know, you have $10,000 to buy either 3 or 4 Polycoms, which is a good deal. I think those are really robust products, or almost 100 of these things, roughly. Okay, so let's see here. This is the our other setups. It's an Android TV telehealth group setup. We use this more for group sessions. So we use these at doctor's offices, and recently we started to experiment in pharmacies because that is another point of access for your members. And then the third setup, which I'm actually most excited about, is this, and that's the home telehealth appliance. Oh, the other thing was, I think, $300. This is we tried to figure out what can we use in a person's home that they could utilize for all their health services. So telehealth services like, you know, diabetes education, maybe a cardiologist, their specialist, maybe psychiatrist, and be branded as a telehealth appliance. So similar to what you use your microwave for and toaster for cooking, this device is specifically for their health. They can get access to their specialists and their doctors. And what we're looking at in the future is to have connected devices like a CGM, like a weight scales or blood pressure monitors right into this, this equipment. So all you have to do is plop this down into their house, and it could be connected or through Wi-Fi, and you'll have this portal between you and the member to create that ongoing relationship. You know, not just when they see you at the office. So, and this one, $175, right? So not bad. So, you know, we have to think out of the box, try to figure out what we can do for our members according to what our organizations need. Let's see. So, so we're coming around to talk about, you know, what makes a successful diabetes program. And we feel that there's a list of the most important things. So the first, or the most, the important things for a successful diabetes program. The first, obviously, is reimbursement and cost, right? If you don't get paid for what you do and you'd still do a good job, eventually you're going to be out of business. And you gotta understand your cost structures. And you know, reimbursement is a really, really complex issue because reimbursement it will depend on your contracts and different and are different in every region. So here in Los Angeles, you know, we have less than 5% of our members that are traditional Medicare. 95% are part of a Medicare Advantage plan. So quite different, I believe, than the other parts of the country. And the majority of our Medicaid, or we call it Medi-Cal here, are managed care as well. So what I would suggest on the reimbursement part of it is really to lean on your telehealth resource centers in your Department of Health department, because they're going to have probably the best information for you for your region. So make sure you utilize them. The other thing is referrals. You know, that's the lifeblood of your program. If you have a hard time getting referrals, you know, I think the first thing you got to do is look at your values and what you are offering each customer, your members, your physicians, and your payers. Yeah. Because they all have different reasons to refer or not to refer to you, right? So we talked about relationships. You got to find that out and see if your value that you're providing is something that they find valuable. Because if they did, then referrals should be coming constantly, right? Next one is access. Yeah. You know, if you have, if you are available to your members, great. If they don't and they have to fight traffic or travel long distance to get your service, right? Then telehealth is no brainer. I mean, you've got to implement telehealth, because if they're driving an hour and a half to get to your place, and there's actually an opportunity to either do it in their home or at a center near them, a doctor's office, a pharmacy. I mean, those are the options that you should be looking at with telehealth. The other part is marketing and PR. You know, are you marketing the benefits of the program, or are you marketing the features, right? What is your marketing strategy to your members and your referrers and your payers, right? Because it'll be different. So have you thought about that? You know, we take it really seriously because that's part of how we want to create and stay with that relationship. So, you know, we do focus groups with our members, and, you know, we come up with different ways to reach them. So one of the things we say is, you know, you'll learn the secrets that no one tells you about your diabetes, right? Because we learn that when people come to our program, they're like, well, I didn't know that. Nobody told me that, right? And so we said, wow, maybe there's a tagline that we can create to entice people to really understand that this is not about coming to 3 sessions. This, you know, this is about learning something that they didn't know before, right? It's real important. I mean, marketing and PR in any business is very important. Another one is, you know, we say, you know, show off your best A1C at your next doctor's office, right? Come to our program. Because if you think about it, members worry. They don't want to go to their doctors because they don't want to be scolded, right? They're like, oh, I got to go, you know, my appointment is next week with my endocrinologist. All he's going to, he or, you know, they're going to do is yell at me and tell me I need to work on it better. So give them a reason to come to your program, because maybe you can help them decrease their A1C so that they can go and be very proud to say, hey, check it out, I did great, right? And one last thing that we do, you know, don't let blame and guilt lead to unsafe blood sugars. You know, we realize that a lot of people that are out there that have diabetes really feel guilty and feel that they blame themselves. And, you know, that feeling is perpetuated to some degree by us, the medical community. And we got to change that. And that's what I mean by patient experience. But the other one is engagement. You know, do you know your engagement metrics? Are your members engaged in your programs that they start? You know, do you know the retention? Do you know the no-show rate? Do you know the completion rate? I mean, these are all metrics that you should know about your program, right? But the most important is this, the member's experience, right? The member's experience is going to dictate whether your program is successful or not. Everything revolves around this, member's experience. And the thing about this is that it's something that you can control every day, right? You have complete control over this. But I'll talk more about that a little bit later. But one advice I will give you is that when you start scaling using telehealth, any problems and inefficiencies in your system will be magnified when you jump into more programs. So make sure that you understand all these metrics like the back of your hand. Brenda, you have a question?
Tony, we've got some questions for you.
Yeah.
Okay, and actually I think the question from Julia, I think it probably both you and Becky might be able to address this. And Julia asks, what if Wi-Fi is not available? And also about rural and or financially challenged patients. And I know, I think it was a previous webinar, Becky had talked about the monies that are available for Medicaid patients to help cover costs of equipment. But I don't know if you...
If you're thinking about the Lifeline program, Brenda, it doesn't.
I'm not sure. So I may be confused. So you can clarify what I've just said.
Yeah. So there's a federal program called the Lifeline program, and I'll put that in the chat so you guys have access to that. And it helps with members to either get discounts on local phone service, just landline phone service, or cell phone service, or broadband access at their homes, but it doesn't necessarily pay for equipment.
Okay. Thank you for clarifying that. I knew there was some way that they help with the finances piece.
Also talk to your payer. I mean, they're interested in your members becoming healthy. They might invest in something.
Okay.
That the payers that we work with do.
Okay. And let's see, Virginia had asked Tony, what is the brand name of the appliance that's like $175?
We're actually creating it in-house, so there's no brand name, unfortunately.
So it's like, you know, like some of those insulin pumps where they're doing do it yourself, make it better.
Right. I mean, there's nothing out there. That's the problem. And so if there's nothing out there, you got to create the solution yourself, right?
Okay. Okay. And then Susie had asked, do you really bring the home telehealth appliance and leave it with the patient?
Absolutely. Why not?
Okay.
You know, you got to look at it as a risk benefit, right? I mean, how much benefit are you going to get if that person gets engaged with you and becomes healthy? You can guarantee that the payers will double down on that. They will put in money to make sure that that member stays healthy, because for them, financially, that $100, $200 is nothing. If that member goes to an emergency room one time, you're talking much, much more than $200, right? So, so it really is a value proposition that you have to create for them to understand that differential. And if you could do that, or if they see that themselves, that's even better, right? But if they don't, you got to make that argument with them, right? And some people will say, you know what, that makes a lot of sense. Let's try it. Let's try it on 10 high-risk members.
Okay. Okay. Susie adds a question. She says, who pays for the device though? She says, we see over 3,000 patients per year.
Yeah. Well, so we work with, again, payers that are willing to pay for some of that. In some cases, if they're not willing to pay for it, we'll put it out of our own money, because we want to create some kind of system that we can market to other payers, right? Because ultimately, if it means that we're doing better at what we're doing, increasing access, getting better results, that's more ammunition for us to succeed in what we're trying to do. So, you know, spending my own $2,000 to get 10 of these iPads, or, you know, it's worth it. And that's, you know, and that's the decision you have to make, right? I don't know, do a GoFundMe. Right?
Okay. Virginia had asked a question. Are you able to do CGM evaluations, for example, time and range?
Yeah, absolutely. So we're with Libra Link, and so we're able to see members' Libra Link data to figure out time and range.
Okay. And then Polly asks, are you billing RPM codes for the device monthly? And do you have a break-even timeline?
Yeah, no. So we don't do any, we don't bill for any monitoring. Our reimbursement is strictly for the consults themselves. Yeah, and a lot of our contracts now have a performance clause to them as well. So what we are looking for is outcomes. We can create an outcome, our business will do well.
Okay, and see if I've got any other questions. I think we've covered them. Let me just double check that I haven't.
I'll go through the rest of it quickly because I know that we only have.
Sure. Go ahead. Sorry, I'm sorry.
Yeah. So like I promised, my 3 secrets to our success. I know you guys all have been waiting, and thank you for staying. The first one is a strategy. Okay, the first 2 are strategies, and this is a slide from our curriculum. It says, I hear and I forget, I see, I remember, I do and I understand. In the doing is the learning, right? This is what we teach our members, because, and this is in our actual curriculum, and it emphasizes how we really learn as human beings. We teach them to experiment while they're in the program and to try different things by doing, right? We use this approach in our curriculum and system because, like all experiments, there is no right or wrong. We are just looking for answers, and we want them to start looking for answers as well. So in the doing is the learning. So give you an example, if you want to do good be good at push-ups, reading about doing push-ups isn't going to work, right? You get better at push-ups by doing it, right? It's the same thing with diabetes, right? Management. And it's the same thing with everything else, including telehealth. Everybody will have a unique challenge implementing their program. And that's unique to your organization, your region. So by start doing and understanding, that's how you'll succeed in telehealth, right? If you always remember, Edison took 1,000 failed attempts before he invented the light bulb, right? And I have a feeling that it's not going to take you 1,000 attempts. The second strategy, if you want to do big things, is this, WIFM. And no, this is not a local radio station here in West Covina. It stands for what's in it for me, right? What's in it for me? So every meeting and interaction we have with our members, referrers, payers, we always put ourselves in their shoes and think, what's in it for them before we think about what's in it for me. So, you know, I found out at our Medicare Advantage payer needed better HEDIS measures and outcomes, right? So my value proposition to them is to improve diabetes HEDIS measures through our program, right? Now, you know, when you do that, you better make sure you can back it up and do it. But that was our proposition to them because we knew what they needed. If you're an educator, find out what your program manager needs to report to their superior and help them make that happen. And perhaps that'll be through telehealth. If you're an administrator or a program manager, find out what your CEO and CFO goals are and help them achieve those goals through your program. That's how you're going to survive, right? So the best way to achieve your goal really is to help them achieve theirs. And you've probably heard this, if you want to go fast, go alone. If you want to go far, go together. And you know, the number one secret to our success as a DSMES is this: members' experience. How does your program make them feel, right? Do they genuinely feel that you are giving them a hug in person and virtually, right? So I want you to look at this picture. Can you feel her happiness, relief from worry, her trust and love? Does your program provide this feeling, or are you just teaching people about diabetes? You know, I like to say that every program is a culture, and the foundation of the culture is the curriculum and the systems that are in place that can select and mold the people that deliver it, right? So, you know, we're really fortunate to become a licensee of a curriculum developed by two CDEs out of Arizona, Chris Swenson and Betty Backenrich, way back when, called the Discovering Diabetes Curriculum and System. And really, that's what's given us our culture throughout our journey. If you're interested in the curriculum, let me know. But remember, people will forgive technical glitches, but they won't come back if they don't feel understood or validated for their beliefs, even when they might be wrong. You know, this is the key to people's experience of your program. Really, really critical. So, you know, unfortunately changes, or fortunately really, changes forced us into this new world in less than 3 months. You know, organizations are forced now to manage change, while others that have always embraced and celebrated change are now at an advantage. We need to evolve quickly or become extinct. We all need to take full advantage of the opportunity and grow, right? It'll be scary for some and exciting for others, but we need to make this possible and not fail. And always remember why you're doing this. It's for them, every one of them. They are counting on you more than ever. So this is the time to take you know, bold steps and make sure that that you raise your patients and your profession. Utilize the resources from your telehealth resource centers and the Indiana State Department to improve and get information about improving your program, whether it be telehealth or not. And this is my gift for you. Some people that are actually starting their telehealth program may need an editable telehealth consent form template, and I have one for you if you want to download it. I also put in, so when the CDC came, they actually created a field briefing. It's a 2-page field briefing about their experience with us, and that's also downloadable. So if you go to the website, you can download both of those reports. And that's it. Thank you so much for being here.
And Tony, on behalf of Indiana State Department of Health, I thank you for your time, sharing your experience and your resources. This was really wonderful. And of course, I thank Becky and Autumn at the Upper Midwest, and for all of you that have joined us today. And please feel free to reach out to myself or Tony. We provided you with our contact information. And I believe, Becky, that there's a survey you've asked people to complete. Is that correct?
Yeah, Autumn will put our normal webinar survey into the chat box. We encourage you to fill that out. It's just 3 or 4 questions, and that gives us information to send back to our funders for the UMTRC program. Also wanted to put a plug in for our Upper Midwest Telehealth Resource Center Conference. Our 2nd annual conference is coming up next month, and it is all virtual. So Autumn, if you'll go ahead and put that link in as well, folks can go in and check that out. For folks in one of our 4 states, Illinois, Indiana, Michigan, and Ohio, we do have a limited number of scholarships available so that you can attend the conference for no cost. Again, it will be all virtual, and we've got a lot of excited things planned. So hope you can join us.
Thank you, everyone.
Thank you.